Greetings, I'm Dr. Park Joo-yeon of Sosanduri Dental Clinic. Today I'm going to talk about the implant prosthodontic treatment for full arch cases. If you look at the classification in AUSA's study in 2011, if the amount of tissue loss is significant as shown, it is called Class 1. If the amount of tissue loss is moderate, it is Class 2. If the amount of interarch space is limited, you can provide fixed prosthesis. This is Class 3. Class 4 is where alveolar bone loss is bare minimum. First, let's look at considerations to be made for diagnosis. In order to analyze full arch or near edentulous cases, temporary denture fabrication is a must. So I make two models and I use one for fabricating provisional denture and another one is used for diagnosis. Kneeback is used to replicate the provisional denture and then I use a semi-adjustable articulator to analyze space on the model. Via X-ray, you need to overall analyze the amount of bone the patient has and also evaluation on vertical and horizontal tissue loss as well as profile needs to be made. Analysis on interarch space needs to be done, as well as on the smile line. If you can understand the diagram, you can understand up to the conclusion. You can provide full denture for a edentulous patient, or if you use implant, you can provide fixed prosthesis or removable prosthesis. Fixed prosthesis can be divided into fixed detachable prosthesis and fixed cerammetal prosthesis. Let's look at the different indications. First, Class 1. Over 50 mm of space needs to be restored. When you look at these patients, it's really baffling. In Class 1 cases with significant horizontal and vertical bone loss, it's very difficult to restore and maintenance can also be extremely difficult. Because the horizontal and vertical cantilever amount is significant, bar over denture where splinting is possible is more favorable. In Class 1 cases, if possible, I use bar over denture, which allows for splinting. The reason is because it is more favorable for profile improvement. This is a prosthesis delivered by a different dental clinic 3 years ago. You can see that fixed prostheses were provided, and in terms of horizontal profile improvement and oral hygiene management, it was not a good decision. Next, I'm going to talk about Class 2. In Class 2, alveolar bone is moderately resorbed. To restore lost profile support, overdenture is the most frequently chosen option. The difference with Class 1 is that you need to use bar over denture to allow splinting amongst the implants, but in the case of Class 2, I use a solitary locator over dentures. In the case of upper, considering the amount of tissue loss, I align teeth and determine the thickness of denture margin with profile improvement in mind. Compared with fixed prosthesis, in a lot of cases, removable prosthesis is more favorable. Because the denture margin was not sufficiently thick, profile was not sufficiently supported. The new denture, it had a thicker denture margin, therefore, profile was improved. This may not be applicable in situations where profile improvement is essential, but implant clasp RPD can be a viable option in the lower where function is more important than aesthetics. It's been 3 years since prosthesis delivery. Recently, I had the patient come back for a recall and the patient was much more plump compared with before, so I thought I had provided my best work even though the conditions were not so favorable. If the patient has low smile line, there are other options. Even though the amount of tissue loss is significant, if smile line is okay, you can use hygienic type fixed prosthesis. It can be a very good option. It can be very favorable for oral hygiene management. Next, I'm going to talk about class 3, where restoration space is about 9 to 11 millimeters. Due to limited interarch space, a fixed prosthesis should be provided. Rather than using overdenture like this was done by a different dental clinic, and you can see why this is a contraindication. In a patient with not so significant vertical tissue loss, if you're planning a overdenture using attachment like this, attachment failure as well as bridge fracture can occur. I provide a fixed prosthesis for the lower. If the amount of tissue loss is not significant, you can provide a fixed prosthesis or implant clasp RPD. Because the amount of tissue loss was not significant, the implant clasp RPD was provided for restoration because of economic condition. I think this kind of restoration is a viable option. Although the amount of tissue loss was not significant in the anterior, it was in the posterior. In this case, you can use implant clasp RPD. In cases where it is difficult to place implants in the posterior area, rather than proceeding with bone graft, I think it is better to do implant clasp RPD. When providing a fixed prosthesis, I place about 8 to 9 implants and segment it into 3 segments. I placed 9 implants in the upper and 8 for the lower, and a fixed prosthesis was provided for this patient. The patient has been using it for 7 years without any problem. In the lower, I normally place 6 to 8 implants. If the bone quality and bone amount and primary stability is appropriate in the lower, I attempt immediate loading, but in the case of upper with bad bone quality, I submerge it and wait 3 months for osseointegration before doing conventional loading. After 3 months, since implant placement, provisional is provided for a month and progressive loading is attempted, and after that, the final prosthesis is delivered. Final prosthesis were delivered for the upper and lower. Implants were placed in the lower first, immediate loading was done. When I placed implants in the upper, the bone quality was favorable and primary stability was good. In this case, I do immediate loading even in the upper so that masticatory function, profile, and aesthetics are restored. Fixed prostheses were provided in the upper and lower. Next, I'm going to talk about cases where restoration space is 8 mm or less. This is class 4. In the case of class 4 with a minimum alveolar bone loss, implant overdenture is contraindication. You need to remember this. If the patient has barely any alveolar bone loss, if you do overdenture, ridge fracture, and attachment failure, along with other problems, can result. Fixed prosthesis is more favorable in this case. This is a case where restoration space was slightly over 8 mm, and even in this case, although compromise may be necessary, implant clasp RPD is also a viable option. In class 1 with significant amount of tissue loss, bar overdenture can be considered primarily. Fixed prosthesis is contraindication. In class 2 with moderate level of tissue loss, overdenture is the general option chosen, and in the case of lower, fixed prosthesis is also a viable option. In the case of class 3 with not that much alveolar bone loss, preferably fixed prosthesis should be provided over denture needs to be approached very cautiously. In class 4 cases with bare minimum alveolar bone loss, there can be many problems if you do over denture, therefore fixed prosthesis should be chosen. Now this is time to say goodbye. In the case of edentulous patient, we cannot provide fixed prosthesis just because the patient wants it. Also, even if the bone condition is good, it is quite costly. So, choosing fixed prosthesis may not be viable. Through this lecture, we looked at different implant prosthodontic treatment methods for full arch cases, and I hope this serves as a basis for successful implant treatment. Thank you for watching.